Welcome. Today, we're diving deep into one of the most intense battles waged in modern medicine, managing infections in the ICU. Specifically, we're going to unpack two major adversaries, ventilator-associated pneumonia and central line sepsis. We'll walk through how we diagnose them, what bugs we're up against, and the critical treatment strategies that can mean the difference between life and death.
You know, in the critical care world, you could almost say the fight for life is the fight against infection. It's not just about best practice. Getting the right antimicrobial therapy on board quickly is absolutely paramount. Every single hour of delay in starting an effective drug can dramatically worsen a patient's outcome. The stakes are incredibly high.
So here's our game plan. We'll start by defining the threat. Then, we'll get into the nitty-gritty of managing VAP and line sepsis. After that, we'll explore some advanced dosing strategies, put our knowledge to the test with a few case studies, and wrap up with the essential principles of infection control.
Right, so at the very core of this entire discussion is sepsis. It's not just a bad infection, it's the body's own response going haywire, leading to life-threatening organ damage. And when that response causes a total collapse of the circulatory and metabolic systems, well, that's septic shock. This is the state we're all trying to pull our patients back from.
Okay, our first major topic, ventilator-associated pneumonia, or VAP. The definition is pretty clear-cut. It's a pneumonia that shows up 48 hours or more after a patient has been intubated. But getting a definitive diagnosis, that really hinges on getting good material from the lower respiratory tract. Think quantitative cultures from a bronchoalveolar lavage, a BAL, or even good quality sputum samples.
So what are we fighting? It's a bit of a who's who of tough bacteria. We see a lot of Staph aureus, we see Enterobacteriales, and of course the infamous Pseudomonas aeruginosa. Haemophilus and Acinetobacter species are also in the mix. This rogues gallery is exactly why you have to know your local hospital resistance patterns, your antibiogram, to make a smart initial choice.
The treatment strategy here really boils down to one key principle: de-escalation. You start broad, that's your empirical therapy. You hit them hard with something like a cephalosporin plus Cipro to cover your bases. But once you get that culture back and you have your target, you pivot. You narrow your fire. If it's Pseudomonas, you switch to something specific like ceftazidime. If it's Staph aureus, you use flucloxacillin. And duration? Well, for a while we thought longer was always better, but now for a straightforward VAP where the patient is improving, a 7-day course is often enough.
All right, let's shift gears to our second major challenge, line sepsis. Those central venous catheters, or CVCs, are absolute lifelines in the ICU. But they're also a direct route for bacteria into the bloodstream, making them a huge source of really serious, life-threatening infections.
The bugs we see here are a little different than with VAP. Coagulase-negative staph is actually the most common one, but honestly, it doesn't usually cause severe trouble unless there's prosthetic material involved, like a heart valve. The ones that really worry us are Staph aureus and those tough gram-negatives, like Pseudomonas. Enterococci pop up, but they're less common.
Now listen closely, because the management protocol for line sepsis is absolutely uncompromising on one point. If your patient is septic, unstable, or has persistent positive blood cultures, the line comes out promptly. It is the single most important step for source control. For high-risk pathogens like Staph aureus or Pseudomonas, it's not even a debate. The line must be removed. We start the antibiotics at the same time, but without removing that infected catheter, you're fighting with one hand tied behind your back.
I love this analogy because it's just so perfect. It really captures the idea of source control. You can have the best antibiotics in the world, but if the source of the infection, that faulty cable, is still in place, you're just not going to solve the problem. You have to remove the nidus.
So we've talked about the what bug and what drug. But we also have to talk about the how much and how often. A septic patient's body is in turmoil, and that completely changes how drugs behave. This is where we get into advanced strategies, really optimizing dosing, using pharmacokinetic and pharmacodynamic principles. You'll hear it called PK/PD.
You can think about it as a 3-step process. First, you have to recognize that in sepsis, with all the fluid shifts and organ dysfunction, antibiotic levels can be all over the map. Second, you optimize. For certain antibiotics, like beta-lactams, this often means running them as a prolonged or even continuous infusion. This helps keep the drug level where it needs to be to kill the bacteria. And third, you monitor. This is where therapeutic drug monitoring, or TDM, comes in. It's like a GPS for your antibiotics, making sure you're on target.
So, which drugs really demand this level of attention? Well, TDM is strongly recommended for drugs with a very narrow sweet spot between effective and toxic, like aminoglycosides and vancomycin. But it's also a really good idea for other drugs, like beta-lactams, in tricky situations. Think patients at extremes of body weight or with kidney function that's changing day by day or very low protein levels. All of these are super common in the ICU.
Okay, we've covered a ton of theory. Now it's time to see how it plays out in the real world. Let's work through a few clinical cases.
All right, first case. Imagine your patient has been on the ventilator for 3 days. They spike a fever. You get a sputum sample, and the lab calls to tell you the gram stain is loaded with gram-negative rods. What's your immediate move? What regimen are you starting? A, oral amoxicillin? B, just IV vancomycin? C, a second-gen cephalosporin plus high-dose IV Cipro? Or D, IV metronidazole?
The correct answer is C. You need that combination of a second-gen cephalosporin plus high-dose ciprofloxacin. Why? Because you need broad empirical coverage for those gram-negatives, and you have to assume Pseudomonas could be in play. The other options just don't fit. Oral amoxicillin is a non-starter for VAP, vancomycin is for gram-positives, and metronidazole is for anaerobes. You need that powerful gram-negative double coverage right out of the gate.
Okay, case number 2. You've got a patient with a central line who is suddenly showing all the signs of sepsis. Blood cultures are pending. What is the single most important, most immediate action you take? Do you A, just start IV vancomycin? B, pull that CVC out immediately? C, order a stat CT of the chest? Or D, give some oral antibiotics and just wait and see?
The answer, without a doubt, is B. Remove the CVC immediately. This brings us right back to that cornerstone principle. For a septic patient with a suspected line infection, source control is everything. It's the most critical first step you can take. Getting antibiotics started is also vital, but nothing is more important than getting that infected line out.
All right, last one, a pharmacology question. For which of these antibiotic classes is TDM strongly recommended when you're treating a septic patient, specifically because their pharmacokinetics are so unpredictable? Is it A, macrolides, B, fluoroquinolones, C, aminoglycosides, or D, tetracyclines?
And the correct answer is C, aminoglycosides. As we covered, aminoglycosides, and vancomycin too, have that very narrow therapeutic window. In a critically ill patient, their levels can be wildly unpredictable. TDM is the only way to be sure you're hitting your targets to kill the bug without causing serious harm like kidney or hearing damage.
We've spent a lot of time on treatment, which is obviously critical, but really the best treatment is prevention. And that brings us to our final and maybe most important section, the universal principles of infection control.
So, to wrap it all up, what are the big takeaways? First, be aggressive about source control. If you think a line is infected, pull it. Second, know your enemy. Use surveillance cultures to track your local bugs and their resistance patterns. Third, identify those high-risk patients early. Fourth, track your hospital-acquired infections meticulously. And finally, none of this works without disciplined, evidence-based antimicrobial stewardship. These principles all work together to protect our patient.
And this brings us to the final, lingering question. We've talked about the best strategies we have today, but the bugs are always evolving. Resistance is a relentless, growing threat. So the real challenge for all of us is to think about tomorrow. How do we adapt? How do our strategies, our technologies, and our entire approach to critical care need to evolve to stay one step ahead?